Hello everyone, welcome along to Paris, to a toy racecourse, the Bois de Boulogne, a perfect setting for this conference. It is the International Conference for the Health, Safety and Welfare of Jockeys. After a brief hiatus, the conference is back. That was largely due to the pandemic in a slightly different form this year. The first person you're going to be hearing from will tell you a little bit more about that. But great to have you here, great to have people in the room, and of course, welcome to those of you watching online from around the world. I'm sure you'll agree that this time of year, for those of you here, there's no better place to be. And of course, it all culminates really with the reason that we all want to be here in Paris, for those of you staying, and that is the 57th International Conference of Horse Racing Authorities on Monday. There's also a race on Sunday, but we'll get to that. That's quite enough of the stand-up. We're here about jockey welfare, of course. We've got three sections for you. There'll be three presentations. The first of them is on concussion. We then move on to spinal injuries, and then the last of them is on mental health of jockeys. There's a Q&A session at the end of each, so please do get involved. For those of you in the room and those of you watching online, you'll be able to submit your questions. If anything that any of our speakers says that you really want to ask about, we encourage this to be as interactive as possible. So please do let your voices be heard. For those of you in the room, there'll be a microphone brought round to you, and you can ask your questions to the panelists. It's well worth you doing so, because we do have some of the greatest minds in their fields here today to speak to you. One of those greatest minds I can introduce to you first of all to really make the introduction to this event. He is the CEO of the Irish Horseracing Regulatory Board. Prior to that was the Secretary General of the Irish Pharmacy Union from 2013 until taking up that position at the IHRB, and also sits as the chair of this conference. So please welcome to the stage Mr. Dara Loughlin.
Thank you very much, Tom, and thank you in particular for that lovely introduction. I can confidently say it is the first time I have ever been introduced anywhere to any audience as a greatest mind. I am hoping that has been recorded for posterity. As Tom said, I extend a huge welcome to colleagues here in the room in beautiful Paris, and also everybody around the world at home. Thank you very much for joining us this morning, this afternoon, this evening, or tonight, whatever the time zone might happen to be where you are. We are very excited to have resurrected the International Conference for the Health, Safety and Welfare of Jockeys, albeit in a different format to how it previously existed. It had stalled, as had so much activity around the world as a result of COVID. We've brought it back in a different format this year, but we are pleased that we are now a constituent committee of the International Federation of Horse Racing Authorities, with all that entails, with the support of the network, the global structure, and what's hugely important, the support of the Executive Office. The steering committee for this conference is very anxious that rather than a standalone event that occurs periodically, it will become more of a forum for sharing of experience, sharing of information, sharing of best practices, development of standards, harmonization of treatment standards around the world as they relate to jockey injury, jockey health. Today we have some fabulous speakers, experts in their field, who will brief us on the latest developments, the latest learning and the latest research in three very important areas. Concussion and head injury is an area that's achieved far greater recognition in recent years in all impact sports and in horse racing. The long-term impact of repeated concussions is now recognised to a greater extent than it had been before. The need for treatment, the need for stand-down periods. Equally, spinal injuries are recognised as being something extremely serious, potentially catastrophic for the jockey, but something that can be mitigated by using the right protection, by using the right techniques, by using the right treatments, and by taking the right precautions. We'll never eliminate risk, but there's a great deal that can be done to minimise it We'll hear more about that later. And lastly, mental health and psychological fitness of jockeys. It's now recognised that being a jockey is a fabulous pursuit when you're on top. Winning a race surrounds you with friends and admirers, but not everybody wins every race, and at times it can be a very lonely existence. It can be difficult to manage the highs and the lows. Historically, perhaps the weigh room was not somewhere where jockeys would share their problems, share their troubles, and lean on each other. We're hoping that we will see changes and improvements in that. We're also hoping to improve recognition of the difficulties that jockeys can face that may not be visible, improve communication around it, and equip jockeys with the tools and the techniques to deal with the difficulties that can arise. It's not all going to be lectures from experts. We're not back in school. We're not back in university. We're hoping it will be quite interactive. There will be question and answer sessions after each of the presentations. And most importantly, at the end, we'll have reflections from one of our colleagues on the steering committee, Tom Scudamore, recently retired third-generation jockey. It's unlikely that any jockey anywhere can speak better or more clearly than Tom, given his family history and his tremendous career history. So we will have Tom's reflections on the conference at the end, and he will hopefully be able to relate some of the academic material that we have heard into a jockey's experience. I'd like to thank my colleagues on the steering committee for the International Conference for the Health, Safety and Welfare of Jockeys, for the huge effort that they've put into this conference today, for the time that they've dedicated to it. We've had numerous meetings on Zoom, and given that the committee is made up of members from around the world, those haven't always been at convenient times, so we have to acknowledge that some of our colleagues have had to get up before dawn or stay up until the party is long over to sit down in front of their computers and plan the programme for today's event. A lot of work has gone into this. I'm very grateful to my colleagues, Dr. Jerry Hill from the UK, Dr. Jennifer Pugh from Ireland, one of my own colleagues in the IHRB, Stephen Higgins from Hong Kong, Myra Federico from Brazil, Tom Scudamore, who has joined to bring the perspective of a jockey who's been a tremendous asset to the steering committee. And we've had huge support from the Executive Office, from Andrew Chesser, who's familiar to all of you, and to Matt Orr, whom we have promised to stop teasing about Australia's recent performance in the Rugby World Cup. We will stop teasing him very shortly. I'll hand you back now to Tom, who will introduce the first of our presenters. It will be Jerry and Jennifer, Doctors Hill and Pugh, each of them with an MBE, who will present on the extremely important topic of concussion and head injury. Thank you very much.
Dara, thanks ever so much. Just to confirm those Australian scores, 46 to Wales and 22-15 to Fiji. Matt, that's it, I promise. I assure you that is it. So, as Dara said, we start with concussion being under the spotlights. So the two people I'm going to introduce, first and foremost, I feel that the best way to introduce them is the people who really oversaw during what I'm sure was one of the most difficult times of their careers during the pandemic, the return of horse racing at such an early stage in comparison to other sports. So thanks to them for that incredibly difficult but important work for our sport. They are the Chief Medical Advisor to the BHA, the British Horseracing Authority, Jerry Hill, and also the CMO, the Chief Medical Officer to the IHRB, Dr. Jennifer Pugh. Dr. Jerry Hill, he moved into sports and exercise medicine full-time following the 2012 Olympic Games and now sits as the CMA on the British Horseracing Authority. And at that same time, back in 2012, Jennifer progressed to racecourse doctor for the at IHRB and then took over the reins as the CMO back in 2019. Jerry is the person you'll hear from first. He sold this as the filling in the sandwich is really Jennifer, the person you really want to hear from, and to take the pressure off himself, he's the fluffy bits of bread that exist either side. So first of all, some bread with Jerry, but you can both come up, and the first person you'll hear from is Dr. Jerry Hill.
Good morning, everyone. Thanks very much, Tom, for that slightly dodgy introduction, although I did set myself up for that by mentioning sandwiches. So my name is Jerry Hill. I'm the CMA at the BHA, and I'd like to thank the IFHA for inviting me to come and talk with you today on the subject of concussion. In traditional way, I have to declare I have no conflicts of interest, but also I'd like to thank those in the room and those watching online for joining us. And I hope you've got plenty of coffee on board because we're in for an interesting time about concussion. So the first session is presented by myself and Jennifer. We'll be taking you through some of the current issues in sports concussion and how they impact on racing. So I'll be starting off, and then as you start to snooze, then Jennifer will step in and save the day. So if you Google sports concussion, other search engines are available. So if you search online for sports concussion, you will come across a number of different headlines. And these are some examples. And you will see the theme here is lawyers, lawsuits, money. And it affects a range of different sports. They are mostly the collision sports, so rugby, under both codes, both rugby union and rugby league, various types of football. So for me, that's proper football, which the rest of the world knows as soccer, but also the NFL and, of course, Aussie rules as well. These lawsuits are affecting both amateur and professional game, and they even go into the collision sport known as cheerleading, where actually one of the participants is suing their coaches for not taking good care of them as a result of concussion. Ironically, as I put this slide together earlier this week, I had an application from a new jockey, and when they apply, they fill in a medical form, and this individual declared a previous concussion. And I thought, well, that's not very unusual. It was the first concussion from a jockey from cheerleading. So there you go. So maybe cheerleading and racing will go together at some point together. The thing about all this is there's good news amongst all this, because there's always a helpful, no-fee, no-win lawyer lurking in the background who's ready to fight your corner, unless you happen to be the regulator, of course. So on that topic, there is anxiety amongst legal and insurance participants about the situation with head injuries and concussion. For instance, we at the BHA have a central indemnity policy which ensures all our medical staff on racecourses on a race day to cover their work there. And it's renewed on an annual basis, and we went to renew it last year. And the underwriters told us that the market was nervous. They were nervous generally, it was all post-COVID, but also nervous about head injuries. And apart from offering us to double the premium we were paying, there was a discussion about the excess on each claim. And historically, the excess on each claim was £5,000 per claim, which is a substantial amount of money. However, the renewal offer increased that to £25,000 per claim until they started talking about head injuries. And when they started talking about head injuries, the excess per claim was offered to us at £150,000. So bearing in mind that actually, even if you successfully defend a claim, the chance of you getting your money back from the plaintiff is pretty slim, particularly on a no-win, no-fee basis, then actually you can understand there is some anxiety there. I'm pleased to say we went to another set of underwriters and we managed to get the original terms back. So it's one of those areas that actually the legal insurance market are beginning to impact on what is happening in head injuries. But it's not just medical legal stuff. You were seen in the previous slide that actually governments are now getting involved in this because concussion and head injury is a cause for concern at government level. And one of the previous slides you saw, there was a quote there from the sports minister in the UK about the concern about ongoing claims may threaten the viability of some sports. It was also there in the Aussie rules note as well. So in the UK in the last couple of years, we've had a parliamentary select committee, which is a fairly daunting process to go through if you're sitting there as a witness. So you sit in front of a bunch of MPs who occasionally do a little bit of showboating, you'll be surprised to hear, but they really drilled down into what sport was doing about concussion. And again, the headline at the time was sport was marking its own homework. And that was slightly unkind because actually sport was setting the syllabus, it was doing the research, and it was publishing its findings as well. But nonetheless, that was the headline which was given. And government in the UK decided to step in. But some good came of that. So off the back of the DCMS inquiry, a number of changes in policy happened. And the first thing was the publication of the first national guidelines for the management of concussion in grassroots sport. I believe it's the first national standards that have been published anywhere in the world. And this was incredibly helpful, not least of all the international committee that we drew upon to help draw up these guidelines included some of the chairs from the Concussion in Sport group who subsequently published the Amsterdam consensus statement. Not only do we now, off the back of this government intervention, have some grassroots guidelines which have been disseminated through the UK and have been well received, we also have the beginnings of a network of concussion clinics in the UK, in the public sector, in the NHS. Also, they put money now into research in concussion. So despite the daunting process of going through this parliamentary select committee, actually, there has been some positive outcomes. And so engaging with government can be very useful. I mentioned in the drawing up of this document, we had input from the Amsterdam Consensus Group. And the Amsterdam Consensus Group, as some of you will be aware of, previously called Zurich and Berlin, the Concussion Sports Group had been around for about 20 years. They've produced 5 and now 6 international consensus statements. And these consensus statements are based on the available evidence. So they review the evidence. And the conference that you see there, which took place in Amsterdam last year, like many things, was delayed through COVID. And that delay meant there was more evidence to review. And I'm told, and I had to check this figure, that actually they had to review 78,000 citations, so that's 78,000 individual papers. I don't think they read them all, but actually there was a huge, huge body of evidence. And as a consequence of that, they produced 10 systematic reviews. And if you're an academic geek, you will know that a systematic review sits towards the top of this pyramid, which is the value of evidence. So at the bottom, you've got opinion, and as you work your way up to systematic reviews, and at the very top, a meta-analysis. It took them 4 years to actually do this, so COVID gave them a bit more time, and there were 114 authors on this consensus statement. I think it's worth noting that a lot of the evidence came from North America, and a lot of the evidence came from sports which were not racing, so they were other collision sports. So that means that, strictly speaking, we should interpret the data with a little bit of caution, but nonetheless, this is very high quality data. It's the best we've got, and we really need to work towards it. So at Amsterdam, there was a good representation from equestrian sports, and we decided at that meeting that once the publication of the consensus statement came out, which came out in June of this year in the BGSM there, that we would get together as a group of equestrian medics and actually see how the recommendations from this document would apply to racing and equestrian sport. So we met online in the summer, and we had representations from around the world and from a range of medical disciplines. So there were physiotherapists, osteopaths, nursing staff, psychologists, neuropsychologists, doctors of varying types, emergency medicine, sports medicine, primary care, and others. And a lot of this presentation are outputs and our thoughts about how this consensus statement might be applied in racing. So at this meeting, the equestrian meeting we had online, we were joined by Michael Turner, my predecessor, and Michael Turner, as many of you all know, has done sterling work in the area of concussion, both when he was in my role at the BHA and continues to work in research. And he's one of the members of the Concussion in Sport group. So in his brief introduction at this equestrian meeting, he reminded us of Zachary Lightsert. So Zachary Lightsert, if you don't know about this young man, in 2006, he was age 13, and he was playing American football and sustained a concussion on the field of play. He was removed from the field of play, but actually later rejoined the game, and towards the end of the game, collapsed unconscious and was taken to hospital. He was found to have catastrophic brain swelling there, a number of intracerebral bleeds, and required surgery to decompress his skull, and was ventilated on ITU for a week before embarking on a long and difficult rehab program over several years, learning literally to speak and walk again. So as a consequence of that, in the US in 2009, the Zachary Lightsert law came into play, and it's now present in 50 states. And this is really quite unusual for a medical condition to actually have a law attached to it. The only other ones I could think of were the ones associated with driving and other medical conditions. So this Zachary Lightsert law, as you can see there are three elements to that. There's a requirement for education, and just to highlight, this is in youth sport, so this is in the under 18, there's a high requirement for education for the athlete, the coaches and their families on a seasonal basis. There's a requirement for immediate removal from the field of play from anyone who's thought to be concussed. And before they can return to sport, they have to be cleared by a medical professional. So this came into law in 2009. And as we move through the rest of the presentation, I'd ask you just to bear those 3 points in mind. So sticking with the medical legal theme for a little while longer, within the consensus statement published by the CSIG, they very helpfully at the beginning put this legal statement in. And what it says, and you can read it for yourself there, is essentially that this document is not a clinical practice directive, okay? It is not a protocol, it is not what you have to do, but it's a guide. It recognises that individual patients need individual assessments, and the advice and recommendations within this publication can be adapted to local requirements, resources, and healthcare systems. So what they're trying to do is head off at the past legal challenges associated with practitioners who perhaps are not following to the letter the recommendations within this document. That's very helpful, but I think we still need to bear in mind that actually lawyers will read this as well, and lawyers will quite often question, why did you not follow the guidance in this document? And to answer, it's because it's just guidance is not going to be sufficient. So we need to have a coherent reason why we've done something different. And that's legitimate and fine as long as you've thought about it. An example of this is in the previous documentation, they produced an assessment tool which many of you be familiar with called a SCAT-5. So SCAT-5 takes you through a structured assessment of someone you think to be concussed, and it takes about 15 minutes. So the lawyers know that, and so if you do an assessment on an athlete who's injured and it takes less than 15 minutes, they will question whether you've done an adequate assessment or not. And it is fine to do it in a shorter period of time as long as you can justify that. So we do need to bear in mind, whilst this is a very helpful statement, we need to consider whether we are going to do something different to what is in the document. So within the consensus statement, they talk about the R's. I have to say that word very carefully. So these are the R's. And there's a bit of a counting issue here. I counted 13 R's, but actually they talk about 12 R's. And just to prove that I did read it, it's because return to learn and return to sport, as you can see here, I've counted them differently, but in the document they count them together. So what are the 13 R's? So the first one is recognise. Okay, so recognising, making the diagnosis of your concussion. Then we get on to the one about reduce, which is an incredibly important one. So this is primary prevention. So how can we stop individuals getting concussed to start with? Okay, and of course in racing, that is synonymous with how do we reduce fall rates. We then move on to remove. How are we going to actually recognise and assess that individual in the acute stage? We then move on to re-evaluate. This is a very American term, so the office assessment. So for me, that means in my clinic room, not on the field of play, but how do I assess that individual moving on? And they produced a new assessment tool for that, which Jennifer will talk about. There's been a tweaking of the rest and exercise paradigm, in as much as we recognise now that exercise is a very useful intervention to help people. There's some recommendations around rehabilitation, how to judge recovery, how do we actually know when someone's over their concussion, and then we've got the returns. So return to learn, return to work. And then we move on to a more difficult area about reconsider, which is what are the long-term issues associated with concussions, and that links into retiring, and then some refined work. And the refined work is looking at groups so far, which has probably not been very well studied. So you can have a bit of a whistle-stop tour of those 13 or 12 Rs. So definition of sports concussion. So this is the definition which came out of the consensus statement and really builds on what we've seen before. So there are no great surprises in this. So it reminds us that TBI, and in this context we're talking about concussion and TBI in the same way, which in itself is a debate. But anyway, TBI caused by a blow where force is transmitted to the head. That blow does not have to be to the head, but the force ends up in the head. And as a consequence of that, within the brain, you get this change in neurotransmitters, a metabolic cascade, which affects blood flow and sets up inflammation in the brain. We know, and anyone in the room who's either been concussed or been treated concussion knows that symptoms sometimes come on straight away, but they may not. They may be delayed. And that's why it's really important that actually, as an industry, we take a group responsibility for concussion, recognising that actually you may not pick it up straight away. Scanning, on standard scanning, should be normal with concussion. And this is a familiar conversation I have with jockeys. They go to hospital, they ring me up and say, "Doc's great, my CT scan's fine, I'm not concussed, can I ride out tomorrow morning?" No, you can't, because your CT and standard MR should be normal in concussion. If it's not, you've got something else going on. The other thing which they highlight again, which is becoming much more common knowledge, that you don't need loss of consciousness to be concussed. In fact, the majority of people do not have loss of consciousness. And then there's this caveat at the end, which is talking about making sure the symptoms cannot be explained by something else. They quote drugs and alcohol here. I would be very anxious if any of my jockeys was riding under the influence of drugs and alcohol, or either. But nonetheless, it has to be there. You need to look for confounding factors. So that's a definition, and that's a helpful definition. But here I am, I'm on a race course. Is this actually going to help me make a diagnosis? Well, to some degree. What they referenced in the CISG consensus statement is this publication from the American Congress of Rehabilitation Medicine. So this was not published at the time that the Amsterdam consensus statement was published, but has been subsequently published. And I would suggest as a diagnostic tool for your medical teams working on race courses, this is a helpful scheme to follow. So essentially it talks about various criteria, and the first criteria is a mechanism of injury. And for us in racing, that is usually pretty obvious. And that really does put us ahead of the curve compared to our colleagues in rugby and football, where actually working out who was kicked in the head at the bottom of the scrum is actually very difficult. So for us, fall from horse or some other collision with the horse makes it relatively easy. It then looks at various criterions looking at signs. So signs are what the doctor sees, the number of symptoms, what the patient feels, the examination, so when the medical staff undertake an examination. And then it talks about various tests. So it talks about blood tests, and these are looking at biomarkers of concussion, which, whilst that is aspirational for us in racing, that is not practical in a race course at the moment. And at the moment, even Ascot doesn't have its own MRI scanner on site. So actually, for imaging, is not really relevant for us in this. It then allows you to make a distinction between confirmed concussion, as long as there are no other explanations, linking back to the CISH group, or confirmed concussion. So suspected or confirmed concussion, or in this chart they're talking as mild TBI. In this document, they do factor in imaging, and they allow it still to be called mild TBI if you've got abnormal imaging. But as I've already mentioned, for a concussion, your imaging needs to be normal. So there is a bit of confusion there on that. But actually, I would suggest this is a helpful way of actually making a diagnosis on a race course on a race day. So this is a version I've tweaked, that I've adapted for this. And this is how it might look. So what we have here, we have our mechanism of injury, so fall from horse or collision from horse, because remember, horses do tend to headbutt you. The most recent jockey I was speaking to this week with their concussion was leading 2 horses out from the field and got kicked in the back of the head. So you do not have to be on a horse to actually have the collision with it, but there will be a horse involved. We then look at the clinical signs, and actually if you look at the paper, it gives you more detail about this. But so these are the things that the doctor sees. So loss of consciousness, you only need one of these. Okay, so you fall from your horse, your loss of consciousness, that's it, you're concussed. It's unlikely you're going to find another explanation for that. So following that through, we also have alteration of mental status, so someone appears confused to you as the doctor, amnesia, loss of memory, and then other neurological signs. These tend to be obvious things, like someone is staggering around the place, or they may have some sort of seizure. So if you've got one of those and a mechanism, you're heading in the direction of a diagnosis of a mild TBI. If you don't have those, then you can base your diagnosis on symptoms, so what the patient feels, and this is how they may feel from a mental point of view, so confused, physical symptoms as well, so headache, nausea, these are things that the patient will report to you. Cognitive, so they feel muddled, can't think straight, and they may be emotional. So, if you've just fallen off the horse, you've just bailed out of the race, so you're going to be emotional from that, but more than you would expect from that. Then there are some clinical examinations and some specific clinical examinations which can be undertaken, looking at cognitive function, so brain function, these tend to be the memory testing ones, looking at balance, and then a whole raft of tests looking at oculomotor function. So this is eye movement associated with movement. I've taken out testing and imaging because actually, as I said, that's not appropriate on a racecourse. So this, for the racecourse medics, may be a helpful way of actually making a definitive diagnosis of concussion, because up until now, a lot of it is based on instinct and actually a global assessment of the jockey. And this will be helpful to either confirm or refute it. Out of interest, if you end up in the suspected group, then actually, usually in professional sport, you're treated as if you were a concussion, but it does give you the opportunity to have a debate later on as to whether or not that diagnosis can be reversed. But actually making the diagnosis, changing the diagnosis after the event is actually very difficult. Jennifer.
Thank you. Thanks, Jerry. Good morning, everyone. The video is just to make sure you're all still awake, although it's still early, so I hope you are. And it kind of just sets the scene, really. This was a 3-year-old hurdle in Roscommon a couple of years ago. Just put the focus on the day of the end user. This is why we're here, to try and make things as good as possible for the guys who are involved in a very challenging sport, as we know. I'll play it a second time. Every time I watch it, I spot something that I didn't spot the first time around. There were no horses or jockeys seriously injured, and actually the most significant injury arising from this race was when one of the loose horses carried out another horse in the subsequent lap, and that jockey actually sustained a concussion. So we don't see this very often, thankfully, or we would, none of us, I think, would be signing up for this job. But yeah, just to set the scene for the day. So Jerry's already started off on our journey through the R's, and I'm the meat in the middle, is that fair to say? Or if there's any vegetarians, will be the vegetables in the middle. So the second R, the R's really are designed to try and take us through from the recognition of a concussion to removing that player to getting a jockey back in a timely manner, hopefully fully recovered and with no complications. And a nice step-by-step wise sounds very easy. In reality, it is much more difficult. So let's just try and put some of the meat on these R's and try and see what's applicable and how we can adapt the guidelines to horse racing. So the second R is to reduce. and this is essentially referring to the prevention strategies, which very much aligns with the vision and the mission of this conference itself, because if we can reduce injuries and reduce falls, we're going to reduce the injury burden. And as the statement talks about reducing the burden of injury, the risk of recurrent injury, and the potential for persisting symptoms. And they break the recommendations down into three areas. The first being policy and rule change and management of concussion. And most of the evidence from this is based in ice hockey and American football. So they've determined that if you reduce body checking, I don't play ice hockey, so I'm not familiar with the term, but body checking, reducing the amount of body checking in adolescents significantly reduced the number of concussions. In American football, reducing the amount of contact in the practice sessions, again, reduced the number of concussions. And anybody who watched, we're going to go back to rugby, so apologies, Matt, if you watched the Ireland-South Africa match, and I believe it was the same for the French and New Zealand match, the impact of rule change and policy change is really significant here, because there were no infringements for high tackles in either of those games. So at a very elite professional level, changing the rules, changing how players tackled, has significantly reduced the number of concussions. And that's in, I suppose, contrast to the French Namibia, where you lost DuPont. I'm sure there's plenty of French rugby fans in the room who fractured his cheekbone due to a high tackle. So policy change, and for the regulators in the room, this is really important that we get the rules correct within racing. Now, some of those rule changes can be less obvious in horse racing because we don't have physical, we shouldn't have physical jockey-to-jockey contact. But by making sure we have policies, that we have recognition and removal policies, that we have on-track facilities to perform concussions, that we have return-to-ride protocols, that we're promoting injury surveillance. All of these are policy and rule changes on how we manage concussion, which very much helps the medics on the ground make sure that we're giving best practice to the jockeys. This is just a graph. We have injury statistics in the IHRB going back to 2008, and it's really important if your jurisdiction, if you're not counting your injuries and monitoring them, you're not going to see trends, able to identify variables that might be modifiable. So really important that you have a surveillance programme which can help determine any changes that we may need. The second recommendation is around PPE, and I still have the horrors of the pandemic when we mention PPE, but for racing it's not face masks or hazmat suits, it's really helmets and mouth guards. And this picture just caught my eye and was one of our racing photographers just last week. This was only last week in atrocious weather conditions in Ireland, but the first thing I can see in that picture is the mouth guard. And we introduced mouth guards to jump jockeys and point-to-point riders in June of last year, so just over 12 months at this stage. And it was really quite an easy policy to introduce. Many of our senior riders were already wearing mouth guards and were strong advocates for them, and so it's been really quite seamless, and the jockeys are wearing them with really little complaints. The research behind the mouth guards is primarily again in ice hockey studies, where they shown a 28% reduction in concussion rates when they introduced mouth guards. Now, it hasn't followed through yet in other studies. If you're watching the World Cup, you'll see them routinely again at that elite level wearing mouth guards, and it's become second nature. So we watch the evidence with interest as it emerges. For me, it's really a no harm policy. We know the impact on reduction of dental injuries, so that's one bonus. And please God, we'll discover that this will reduce our concussion rates down the line, and we watch the emerging evidence with regard to that. One thing to note, that the evidence in the ice hockey study relates to a very specific direction of impact, which is primarily an impact to the chin. But we do have a lot of jockeys falling head first, and we do get a lot of kicks to the face. So to me, this is a really easy win for us in horse racing to introduce the mouth guards. We haven't gone down the road of flat jockeys yet. That'll be a harder sell, but we'll see where that one takes us once we have it well established and embedded into the jump jockeys. In terms of helmets, we know the primary function of the helmet is really to stop to reduce skull fractures from a direct impact, but evidence is ongoing, and I think ultimately we will have an evidence base back that they do reduce concussion rates as well. And I'm often asked, what's the best helmet? What helmet should I buy, doctor? And I say the best helmet for you is the helmet that fits you best, because every helmet has a very slightly different shape, and every rider has a slightly different shaped head. And that was borne out in the studies in the concussion or the consensus statement as well, that studies where American footballers and then lacrosse players wore helmets that were correctly fitted and approved fared much better than just buying an off-the-shelf helmet. So helmets are really important. There certainly is further research needed, though. MIPS technology has been around for a while, but the benefits are not yet well established. But there are a couple of immediate actions that we can do in the short term. This picture was of last year in Ferryhouse, and this is how well trained our jockeys are. So this guy has had a fall. We're walking back to the medical room, and he's already taken off the silk and handed me his helmet to check it, because they know that's what happens after every fall in Ireland, is we check your helmet. And the aim is really to make sure we get damaged helmets out of circulation. Jockeys will always say, "Oh no, I'll take that home, it'll do me for riding out." So, well, your brain is equally as important when you're riding out in the yard as it might be when you're in a race. So really important to get those helmets out of circulation. And you don't need any huge training on this. Any healthcare professional, any medic on the course can check a helmet after every fall. And I think that's something we should all be doing. We're also very fortunate that there's a bounty scheme. So the Irish Injured Jockeys Fund will give €100 towards every jockey who has a damaged helmet that needs replaced. And again, it just softens the blows, particularly for guys early on in their career. Those are two things that you can do, that all of us can do, to keep the focus on the helmets. The training strategies, this is probably a relatively new area to horse racing. It's the studies in rugby have led the way, where they've shown neuromuscular warm-up programs have reduced concussion rates on the pitch. Warm-up, if you're dealing with jockeys in a day-to-day, is kind of a bit of an alien concept. It's probably the only sport where they don't routinely warm up before they compete. But there may be some evidence that warming up in general may reduce fall rates, and if you reduce fall rates, you're going to reduce concussion rates. There's also some evidence, or certainly it's all anecdotal, I suppose, rather than evidence, but introducing falls training or schooling programs may well also help our jockeys. When we analyse our injury stats every year, I would say, routinely you see a half dozen jockeys who are way outside the norm in terms of their fall per ride rate. So should those guys be gently pushed into a schooling program if it's for jump racing, or if someone's continuously been pulled up for improper or careless riding, should they be put on a course where they might learn to ride more safely? The falls training, we did a very valuable session, I think, with our apprentice jockeys last May, where with these really cool skater-type base jump guys came in and taught them how to tumble over. And when you look at these guys when they fall compared to how a jockey falls, and there's no normal way a jockey falls. We'll hear from Dal later in the spinal injuries, who's analysed hundreds of falls at this stage, and they all fall slightly differently. But this fall on an outstretched arm or fall onto a head is where we're seeing a lot of the injuries. So very simply trying to teach and train jockeys how to tumble over. So that's kind of an area that we need to probably do some more research, and I think it's probably going to be one of the more interesting areas as the years progress that we can look into. Excuse me. So the third R is remove. Removal from play or removal from race riding, and it's probably one of the most important R's in the entire sequence, because if we don't recognise and remove that player, then the rest of the steps really aren't relevant, because this guy or girl is continuing to ride and to compete without managing their concussion. So we're very familiar with the recognise and remove, the if in doubt sit them out policies and the campaigns, and really the aim is to try and avoid further potential injury. So somebody landing on an already injured brain, and also they're much more likely to get another fall because their vestibular and their balance system is damaged from the original concussion, and now we're putting them back up on a horse where they need to have very solid reaction times, and their balance centre needs to be fairly well primed. So in the consensus statement, the first point is about the immediate evaluation and the red flags, and they give us a lovely flow chart here which talks through the red flags. Now for me on the track, the red flags are the big sick. These are the guys that we package up, spinal precautions, taken to hospital for definitive care. So they're going to go for the head scan. They're generally the patients who have had a significant loss of consciousness, who remain significantly confused or agitated, or having another injury. So the big sick are kind of the ones that we hope that we're not going to miss. They get taken off. And then we have the cohort of jockeys who fall, who are clearly fine, fairly innocuous fall. They get up, they're fully making sense, they get into the ambulance, they come back in and they're okay. And then we have the cohort who are concussed. And it's been able to identify those concussed patients and in and amongst the non-concussed patients that we really need to focus on. The big sick you're not going to miss, I would hope. And some of the changes and differences, many of you will be familiar with the SCAT-5, which has been around since the Berlin conference. We're now moving on to the SCAT-6. They put an emphasis on the visible signs, and this, Jerry has alluded to this. This is the loss of consciousness, the confusion, the memory loss, the seizuring, the tonic posturing. Somebody who gets up, and we've seen the videos, particularly in American football, where the guy gets up and stumbles and tries to play on and stumbles and falls over again because his balance is so poor. And it's very important. We're very lucky in Ireland. Our stewards room will often video the the fall in slow motion on the lovely big screens that you have in the steerage room, and they'll WhatsApp it down to the doctor on the course. So you might, within minutes, get a picture of the mechanism of injury. We've also done some training in Ireland with our racecourse staff, so the guys who stand at the fence to put up the bypass or to tread back in the ground. We've done some training with them to emphasise you're the closest person to this fall, so how did they fall, what was the mechanism of injury. So now we have a lovely scenario where these guys will come over to us and say, oh doc, he definitely got kicked in the head, or he was definitely unconscious, because often by the time we get there, for the jockeys in the room and on the call, your job is to try and make sure you don't get stood down, unfortunately. So you're up looking, trying to determine where you are, trying to see, get the answers to the questions you're going to be asked. So it can be really useful if you have some video footage or somebody who's there at the fence or at any part in the course that can see what's happening. And those things are all, you need a lot of information when you're making the diagnosis of concussion. So try and use as much as you have available to you. The Maddox questions, again, they've been around for a long time, and we tend to make them sport-specific in racing, so there's a series of questions to ask. And again, this is very low resort. You don't need any highfalutin medics to do this. You just need someone familiar with the questions. What track are we at today? What did you ride? What number was the horse? Who was the trainer? Who was last year's champion jockey? Or who was last year's entry or Derby winner, who I still always have to remind myself I'm a huge jump racing fan. Flat racing still eludes me a little bit. But probably from my own experience, sometimes it's about spending a little bit of time with that jockey. So getting into the back of the ambulance with them, general chat, have you ridden already today? Or what do you ride next? Or who did you travel to the races with? Kind of unbeknownst to them, I'm doing an assessment. They think I'm just making small chat. And to borrow a term from my colleague, Ciara Lostry, who you'll hear from later, strategic loitering. So I'll often go back to the weigh room with the jockey. Oh, I'll carry your helmet back. Because you're getting that extra few minutes that might alert you that something is going on here. And I might pretend to talk to somebody else, one of the officials or the valets within the weigh room. And in the corner of my eye, I'm looking back and looking at that jockey. Has he gone to the right clothes peg? Is he getting on the right colours for the next race? And all of these signs, particularly for the evolving and the delayed concussions, are really important, because within the few minutes in the medical room, out they go again. And the symptoms may be evolving within the next 10, 15 minutes. So really important to make a bit of a nuisance of yourself if you're worried that somebody may have a concussion. Sorry, I want to go back there. Sorry, symptom scales then really important, and this was part of the SCAT5, and I'll speak about it actually in more detail when I move on to the re-evaluation slide, but really important, and really important for us to get a baseline. So what are the symptoms at the time of concussion? So when you see them back in the clinic the following week or a few days later, you have something to compare to. The 5-word, which is for the immediate and delayed recall, so it's for the cognitive function. It used to be a 5-word list, it's now up to 10 words. The months in reverse order, they've made that a little bit more difficult. You have to do it in a certain time now. I think they're just trying to add a little layer of complexity. And the balance testing certainly is a little bit more complex. So those of you who do this a lot, you'll know the modified BESS, which is where we do, it's basically double leg stance. You stand with your 2 legs together, hands on your hips and close your eyes. Then you do tandem, 1 foot in front of the other. I'm not going to do it in high heels. And then single leg stance. So they've now added in the timed tandem gait. So we're going to need the big white strip of tape along the floor of the medical room where a jockey walks in tandem up and down the white line to see if they can do that. And then the dual task, and that will be an interesting one. So dual task is where you're asking them to do the tandem gait while doing the months of the year in reverse order, or serial 7, so 100 take away 7, take away 7. So it's just adding a layer of complexity for those very subtle signs that we may miss. This is just a video to show you of, I suppose, a concussion. This is the big sick. These are the ones that get packaged off to hospital, and that, as I say to you, I hope that we're not going to miss this one. It's, sorry, the black and the yellow armlet and the yellow cap. So again, it's this impact on the head and then this falling around like a rag doll. Jockeys will often tell me, oh no doc, I wasn't knocked out, I was just staying still to make sure the horses didn't kick me on the way past. And I said, well, if that was the case, you would surely get yourself into a tight little ball. You wouldn't lie spread-eagled out on the track. But again, all useful signs, and really useful for the defence marshals who would be standing there if you don't get a good view of it. So that's the SCAT6. What we do in Ireland, and I think is probably what the majority of us are doing now, is we screen all fallers for concussion, even the guys who are very well. We do the questions, we do the balance testing, we check the helmet. You get that few minutes with the jockey. And in general, they're divided, as I said to you, into you're definitely concussed, you're big sick, you're off to hospital, you're clearly not concussed, you're cleared and you can go. For the ones who are concussed, though, I still think they probably fall into two categories. There's the concussed jockey who is obviously confused, has a period of amnesia. Like I say, oftentimes they don't remember anything. They often remember being in the stalls, or they remember taking off at the takeoff side of the jump, but often nothing after that until they maybe 15, 20 minutes later. And sometimes for those obviously concussed jockeys who you're trying to do the SCAT6 on, it can be quite difficult if someone's acutely concussed, because they get a bit distressed. You're trying to get them to quote numbers back to you and remember the 10-word list and do a balance test, and that can be quite difficult. So I don't always do the SCAT6 on the very obviously concussed jockeys, because it may or may not add anything. You know that they're concussed and they're being stood down. What can be helpful, though, is the symptom scores, or the immediate and delayed recall, because it's good for a baseline, so when you've got something to compare to when you see them back in your office again. But the SCAT6 comes into its own really for those jockeys who the signs may be very subtle, and they may not be obviously confused. Adrenaline is up there. They have a remarkable ability to do really well in their balance test, to remember the answers to the questions. So the SCAT6 is really important for that. But the other key point is around logistics and the rules to support how we assess jockeys on the track side. And the first one being, as Jerry said already, this is at least a 10 to 15 minute assessment. And for most of us, there's a 30-minute turnaround, maybe shorter time between races in some jurisdictions. To the time you get back into the medical room after the race, if that jockey's riding in the next race, they really need to be weighed out probably 10 minutes before the off time. So you probably have a small window of maybe 10, 15 minutes in which you're meant to be doing all of these tests. And that can be really challenging. The assessment certainly needs to be done in a quiet place, free from distraction. Jerry will know I'm guilty of running in after the Aintree National when there's 20 Irish jockeys trying to catch a flight home and running through the questions and the balance test in the busy weigh room. Now, I'm not totally reckless. These are jockeys who I know well, who've had a very low suspicious fall. However, it's not enough. You need to bring them back into the medical room where it's quiet and free from distraction. Trying doing a balance test with a jockey in a weigh room as another dozen jockeys walk back and forward past them is not appropriate. So you need to make sure that your racecourses have a room available for that. And if you don't have a jockey's medical room, you need to go to each racecourse and make sure somewhere it's identified that you can do this assessment in quiet and with no distractions. The timing between races, I think it's particularly pertinent if a jockey is riding in the next race. And in Ireland, we have a rule, and I think it's the same in the UK, whereby a jockey can be stood down for their subsequent ride in order to give us time to perform the head injury assessment, and then allowed to return to riding if that assessment is clear. So the jockey won't be happy, they're going to lose one ride, but the alternative is, well, we can't make the assessment in this time, therefore you're stood down for the entire day. So again, you need your policies and your rules within racing that allow that to happen, allow us to have time to assess a jockey. If it means they miss one ride, that's okay, but if they're clear, then they're back to riding the rest of the card and back for the next day. And the final point is just to make sure that you have somebody who is trained and experienced in doing these assessments. It needs to be a healthcare professional who has experience and who's familiar with the SCAT6, who's familiar with concussion, because these will be missed if you have somebody inexperienced or if your jockeys are not being checked by a medical or a healthcare professional after each race. So having said all that, it's still not easy, okay? So this is Patrick Mullins, our champion amateur jockey. He rode his 800th winner last week, son of our champion trainer, Willie Mullins. And I'm not breaking any confidentiality because Patrick wrote and told his story very articulately in the Racing Post after a fall in Punchestown last April. So he had a fall in the Hunter Chase. It was a heavy fall. He was taken back in. We were tied up with another injury later on in the race, and a very experienced medical officer on our team checked him over. He passed his concussion screening test and proceeded back into the weigh room. And he rode in the last race, which was about 2 races later, he rode in the bumper. So he describes being in the parade ring and looking over his mother's race card to see what number he was due to ride, because he wasn't sure which horse he was getting up on. At the start, he asked his colleague on 2 occasions, what day is it? He rode in the race, came back in. I went into the weigh room. I would routinely do a sweep of the weigh room after every race meeting that I'm working at. I often joke is to make sure there's no bodies on the ground. But I do a quick check that everybody's okay. And his 2 housemates were our fellow jockeys. I said, actually, is Paddy okay? He had a heavy fall. Yeah, he's fine. He's in the shower. We're just waiting to bring him home. Turns out this was the second shower he'd had, because he'd showered first, came back out, hadn't remembered he'd had his shower, went back in and had his second shower. So that's fine. I went back home. At 9 o'clock, a phone call from his housemate, because it was a little bit unusual that this person would ring me. Yeah, just really worried about Paddy. He still can't remember, and he's asking the same questions all the time. And so, what do you mean he still can't remember? This is the first I've heard of this. So first of all, my shock at how did I not know? I know everything that happens on the racecourse. And then I quickly thought, my goodness, this is now 4 hours after his fall, and he remains confused. So it all's well that ends well. We sent him to hospital. He had normal imaging, a period of observation, and he recovered from his concussion quite well, very well, sorry, in about a 7 to 10 day period. But it goes to show I would have hoped that these days were in the past, because generally and honestly what happens a lot in our weigh room is colleagues or racing officials or trainers will often come back to us to say, will you have another look? I'm just a little bit worried about that jockey. They're just not quite right. And we'll go back in and reassess, because we have to remember about the evolving symptoms that can occur and about the need for education. So Patrick would have been in the weigh room with his colleagues, with his housemates, with his family, with his colleagues in the race, with the valets, with other racing officials, and still nobody alerted us to the fact, and they all knew that he was concussed. I kind of wondered, because he's high profile, if it had been somebody less, maybe someone would have come to us, where is this, oh, I don't want to tell tales on Patrick because of who he is. And in fairness to Patrick, he wrote the article not to throw me under the bus, but to kind of highlight that this can happen and that we need to be vigilant. And he wrote very articulately about the need for everybody within the industry, everybody on the day on a race course, to be educated and to understand and to recognise the signs of concussion if they're not immediately obvious to the medics. So that's our remove. So reevaluate. The SCOAT 6, so Sports Concussion Office Assessment Tool, and this is new to the concussion statement, and it's really to so after we've removed the jockey, they've been to hospital or they've gone home and they've rested, and you're going to see them in a few days' time to see how they're doing. And it gives us a nice guideline for that. The kind of preamble to it is to give healthcare professionals a standardised, expansive and age-appropriate clinical guide to a multi-domain evaluation in the subacute phase to guide individualised management. So that in itself is a mouthful, and when you open up the SCAT 6 you kind of go, oh God, where do I start? Because it is quite a lengthy document and it takes a little bit of time to get used to. So it's like the SCAT 6, only it's really buffed up. It encompasses all the relevant domains. It takes you through each assessment in section by section, but there is a complexity to it, and you're asking a concussed patient to do a lot of complex assessments within this. So you really need to have your wits about you as a healthcare professional, and you need a lot of patience to get through this. But to kind of break it down, like I said, it's nicely laid out in the particular sections. Symptom scores, as I've already mentioned, are really important, and even if you don't have the symptom score from the day, when you do this in your office, you can immediately start to see just the burden of injury that this jockey may be suffering from, and you can highlight the particular areas already that may be affected with their concussion. And it's really nice then, the last guy I had on his initial meeting, we had, I think it was 11 symptoms and a symptom score of 36. A week later, he was down to 4 symptoms and a symptom score of 11. So it's something nice and tangible, and you can give that to the jockey to say, actually, look, you are getting better, particularly if they're getting a little bit frustrated when they're hitting sort of the 10, 14 day mark. So it's a lovely, tangible way to monitor progress. The cognitive tests, as we've said, are the 10-word recall, the digit backwards. They've added in standing and lying blood pressure, which is the autonomic system. Again, I know there's a lot of non-medics on the call today, but the autonomic system is what regulates. One of the things that regulates is our blood pressure. So it's, again, just a little reminder that we need to be checking that system as well. An emphasis on cervical spine assessment. If you land heavy enough to have a concussion, the risk is almost certainly there that you also have a neck injury, and a lot of neck stiffness, those whiplash injuries, can contribute to the headaches quite a lot. So cervical spine assessment, neurological, which we know. The balance testing, again, gets a little bit, I'll leave that off for a second. The balance testing gets a little bit complicated. There's the modified best that we're familiar with in the SCAT 6. There's the tandem gait, which is your white line in the floor, walking up and down, heel to toe. Then you've complex tandem gait, where you're walking up and down heel to toe with your eyes closed, forwards and backwards. And then there's a complex dual task, where you're walking in tandem gait up and tandem gait is just your heel toe along a white line. So you have your dual task, where your serial 7s or the months of the year backwards. In general, and my experience already having done this, is if someone doesn't get past the first modified best because they're so symptomatic, you don't progress to the rest because you know they're not going to be able to do it. And it can be, again, quite distressing for a jockey to do these complex tasks. But what can be nice is when they come back through the recovery phase, the next time they come back to you, actually you are able to do the tandem gait. And the next time you come back at 2 weeks or whatever time frame your recovery is in, they're able to do the complex tandem gait. And again, a nice encouraging sign for both the injured jockey and for the doctor or the healthcare professional to actually have something tangible there to guide their progression. And the modified VOMs I'm going to come back to in a second. That's the dual task gait testing. And they also have a nice reminder about anxiety and depression. So we know the emotional impact that a concussion can have on jockeys. And these are often maybe feelings and emotions that they haven't had before, or for some of them that they're unmasking symptoms that they would have had. So again, my experience in the last few weeks, even when you put this in front of a jockey, they immediately go, oh, actually, that's part of my concussion. That's why I feel this way. A lot of them come in really unmotivated, really, I don't really want to do anything. I'm just happy to sit there. You have to really kind of push to get them onto we'll move on to exercise in a moment. But it's a really nice tool. And the same with the sleep questions. So to actually give it to them and let them read down through it can be really important. And actually, that's the same with the symptom scores. A lot of jockeys won't identify those symptoms as being related to their concussion until they see them down on paper and go, actually, I do feel this way. Whereas if you just ask them outrightly, how do you feel? What are your symptoms? You get, oh, I'm grand. But you actually write it down and make them look at it. It's a really, really useful document. This is the VOMs. I've borrowed these stills from a lovely video that the injured jockeys in the UK take part in. And again, when you sit down to do the VOMs, if you're not users, so VOMs is vestibular ocular motor system. So very commonly in concussion, the vestibular centre of the brain, which relies on the ocular, the visual input, can be disturbed. I'm trying to explain this in some kind of layman terms, Jerry, so don't look at me like that. But certainly when you read this, you kind of go, oh God, how do I do this? But if you break it down again, it is achievable. The picture on the top right is when you're doing your smooth pursuit. So that's holding the tongue depressor in front and moving it from side to side with the rider moving their eyes, keeping the head still. The saccades then is the bottom right, where you've got 2 fixed points and you're asking the jockey just to move their eyes, not move their head, move their eyes from one to the other, and you do 10 repetitions. The vestibular ocular reflex is where you're holding the tongue depressor or a pen or whatever you have in your office in front of you. The eyes are kept still, but the head is moving. Okay, I did that wrong. Sorry, eyes are kept still on the point and you move your head. It's done at a certain pace. And then the vestibular motor system is your 2 thumbs out in front of you and you're asking the jockey to move, focusing on the thumbs. So it does sometimes, like I say, feel a little bit overwhelming, but you can be really, again, subtle signs picked up on these tests. And while you're looking for any obvious abnormal eye movements, the other really important part of this is, does it make the jockey feel worse? So do you feel nauseous? Is your headache worse? Do you feel a bit foggy? Is it difficult to do these tasks? And again, that's indicating that that may be the area where you need to focus your rehab on. So that's the VOMs. So the really important part really is it's multimodal and multi-time points. So multimodal, you can list off all the different systems that we're checking. So the symptoms, the cognitive function, neurological function, the cervical spine, the autonomic system, our balance, our vestibular ocular system. We're looking out for mental health, for their depression and anxiety score, and at a multi-time point. They do mention the neuropsychological testing for those of us who are lucky enough to avail of it. It's very valuable, either the computerised or the pen and paper test. And again, really useful way of tracking someone's progress, but that cannot be used in isolation. So if you have access to one of the cognitive computerised tests, doing that alone is not enough. You need to actually have your patient in front of you doing these assessments. And my experience is certainly in the last few months that this is helpful. You do need to have your wits about you. You need a little bit of patience. This is your guiding document, which will be your saving grace. Keep it beside you. It gives you really clear instructions on how to do the test and how to do the VOMs. But I think certainly again, this is something, once you have somebody who is trained on the SCOAT 6, is familiar with doing it and is doing it on a regular basis, you can offer your jockeys a really thorough assessment in the subsequent days and weeks after their concussion. So rest and exercise were number 5, so stick with me, we're doing well. Rest and exercise, and this is effective for reducing the likelihood that someone's going to get persistent symptoms. And if someone does have persistent symptoms, it's also useful in their rehabilitation there. And relative rest is not a new concept. We all remember the days when you're told to go into a dark room, put on a pair of sunglasses, stay there for the week, and come out 7 days later, you'll magically be better. So we now know that is not how concussion recovers, and in fact, it makes things worse. But relative rest needs explained, because you either have the cohort who do go into the dark room because that's what their granny said they should do, and the cohort who go back to work the next morning. So you you really do need to explain. You need to go home. They describe it as being allowed to do your activities of daily living. Again, that's a term that medics use. What that means is go home, get up as normal, have a shower, have your breakfast, get dressed, make your lunch, go for a walk around the garden, but you don't do anything more than that for the first 24 to 48 hours. And screen time, really important that you remind your jockeys who are concussed to reduce their screen time. That's obviously phones, iPads, television, computers, but there's no real benefit in the reduction shown in the consensus statement review of the literature past or anything beyond 24 to 48 hours. And what is important is this early return to physical activity within nearly as early as day 2 after injury. And this has been shown through all of the systemic reviews to aid recovery. Now, again, it's a little bit of a mouthful. It's prescribed sub-symptom threshold aerobic exercise based on heart rate threshold. So it basically means sub-symptom means you don't want to make them worse. But actually, a little bit worse might be okay. So if you have somebody on a symptom scale, once their symptoms don't get worse by more than 2 points on the scale, or they're not significantly worse, and if those symptoms only get worse for a short period of time, that is actually okay. You can then progress to the next stage, whereas before, if we had any symptoms that were worse, you were told to stop and go back and rest. But a little bit of a little mild exacerbation of your symptoms is allowed at this stage in your physical activity return. And heart rate threshold, again, there's recommendations as to what training zone you put somebody in the initial phase, and then you systematically step that up and increase the intensity. So, I mean, ideally, this is done in a rehab centre, in a gym, whether you're a strength and conditioning coach or a physio, you put on a heart rate monitor, and in fact, I think a lot of jockeys who are very symptomatic like that because it gives them confidence that you're doing it with somebody in case something happens. I often tell jockeys, well, I told you to go for that jog for 5 minutes. Did you do that? I went, no, I didn't feel great. I didn't know if I should. So sometimes bringing them into a gym can be helpful. But if you don't have that, if you don't have a rehab centre, if the jockey geographically is far away from you, you can, with really clear instructions, allow them to do this at home unsupervised and self-determined if they're well clued into it. But it does take jockey buy-in. They'll immediately ask, well, why can't I ride the horse? What good is running? And a lot of jockeys don't partake in much cardiovascular exercise, so asking them to do a run or a cycle can be a little bit like, oh, is she mad? I want to get back on the horse. But the key to this is obviously keeping them off the horse. And the second thing, just to remind you of, is other injuries. So my 2 concussions from last weekend, one has a fractured clavicle and one has a fractured femur. So it's going to be very difficult for them to get some cardiovascular exercise there. But what's really important for me is that we don't forget that they still need to rehab their concussion. Generally, they don't panic too much because they're going to be off probably 6 weeks and 6 months respectively with those injuries, and we would expect their concussion to have resolved at that stage. But I think sometimes, again, the focus is on the physical injury, and we kind of can easily forget about the concussion injury. So just a couple of things, add-ins after you've done the cardiovascular element, then add in sport-specific exercise. But again, really difficult to keep guys off a horse. More often than not, I ring a jockey the next day and you hear the clip, clop, clip, clop. Oh yeah, I feel great. After riding out 2 lots, you go, oh. So really important. So you can't get back on the horse until you're medically cleared. And again, the risk is that they'll get another fall and another injury on a brain that hasn't fully recovered. Simulators are great because it's sport-specific, and they are more widely available in most jurisdictions. I think it's quite easy for jockeys to access them. But again, just the important step to avoid re-injury. And what can be really helpful part of recovery is going back into the yards that they work in to do the general yard work. So it's very good for the emotionally and mental health to be in that yard, talking to colleagues, getting back into the hustle and bustle of a yard when as part of their recovery. But if anyone's ever been in a training yard, if you're in there and you physically look okay, why aren't you riding a horse? And before you know it, there's peer pressure for them to get back up and ride out. So it can, and I hear this a lot from jockeys, to kind of go, yeah, that sounds great, I'd love to go in, but there's no way I'm going to go in there and not be asked to ride a horse. And the other thing to remember is racing yards are, like any agricultural environment, are fraught with risks other than when you're on a horse, like that, being kicked by a horse leading out, a horse headbutting you, loading them onto the trailer or on and off the walker. So it's a really difficult environment. And sometimes, or a lot of the time, what we find is jockeys going to maybe a family member or a friend who's got a smaller yard or small riding stables, or just to try to mitigate that risk. But it can be challenging to get them into the yard without being there to ride out. So that's rest and exercise. Refer. This is really where you're trying to highlight the guys who aren't doing so well and may need referral onwards. And again, it reiterates the importance to reevaluate, to be bringing them in every few days or week, depending on their progression, so that you're spotting the symptoms that aren't doing well. Particularly if you look at the SCO at 6 and you're doing those particular assessments of each individual system, you will pick out the areas of somebody if someone's really in difficulty and not getting better. The guidelines will suggest 4 weeks. symptoms persisting more than 4 weeks. I think in any elite athlete or any jockey, if you tell them, well, we won't worry about that too much for another week or two, when they're expecting to be back race riding by week 2, 4 weeks is probably too long, and I think we're going to be seeking some input sooner than that. And there's a whole host of symptoms there that you can see that you may end up needing to refer a jockey to. And who you refer to, again, very much depends on your jurisdiction, what resources you have available to you, what specialties you have available to you. But there's an entire range. Certainly physiotherapy, hugely important for neck pain, which then relieves the headaches and allows jockeys to free up a little bit and physically feel better. Neurophysiotherapists or physiotherapists with a particular interest in balance disorders are really helpful to do the balance rehab. Occupational therapists, excellent when it comes to cognitive training or cognitive rehabilitation. And then all of our colleagues in medicine, so the ophthalmologists, the psychiatrists, we'd be lost without our colleagues in neurology and neurosurgery for advice on the guys who really aren't doing well. But just to remember, pre-existing or co-occurring conditions, it's not uncommon for other conditions to be unmasked, particularly mental health issues. And I've had several jockeys over the years suffer from anxiety and depression. That was probably there beforehand, but the concussion brought those symptoms to the fore, probably opened the door and allowed them to talk about it, and certainly made those symptoms and those conditions worse. So a really important caveat, just not to forget to look for other conditions, and certainly people who may have learning difficulties or other medical problems. And again, as I said, probably we're going to refer them off before the 28 days when they're screaming at your door, why am I not back? And rehabilitation then kind of forms part of this. We know certainly that this multidisciplinary approach to rehabilitation can and does work, and certainly gets jockeys back sooner. Again, highlights the importance of the SCOT-6 to identify where your rehab needs to be targeted, or is it general rehab. The authors will conclude that some of this is not yet well established in terms of the combinations of rehab and the timing, so more research is needed there. But there are some generally basics that everyone should be doing. I've already mentioned physiotherapy, which can help with the neck pain and headaches. If you're having someone who's having difficulty progressing through the exercise phase, make sure you get them into a supervised lab where somebody can put the heart rate monitor on, can build their confidence and getting back to that form of exercise. And the vestibular ocular rehab is really important as well. And these are just some stills taken from a video that we would use to show jockeys what they do. And again, this is zero resources needed for this. You need a football, okay, so and a little bit of space. You don't need to be bringing people into highfalutin fancy rehabilitation centres. This is something that is achievable for everybody. And it's very simply standing on one leg, throwing the ball from side to side as you're doing your tandem gait. And there's lots of useful videos like this to highlight those visual cues that you can send to your jockeys. They can be doing this at home in their bedroom. You don't need huge resources for this. And this is a video, again, borrowed kindly from the Injured Jockeys in the UK, just to show this happening in real life. I'm not sure if we have any South African colleagues on the call, but what a great match on Saturday. Commiserations if you're from South Africa. Well done, Ireland, and who knows, you might meet again in a few weeks' time. Matt, the pressure's off you for Australia for the moment. So again, these are they're relatively simple once you're able to articulate that and visually show a jockey how and what they should be doing. And a really, really important key to rehabilitation, because again, the jockeys may not, it's only when you test their balance that you'll know it's abnormal. So a lot of the time they come in and go, oh no, my balance is fine, but they haven't been up on a horse yet and they haven't done any of these tests. So really important that you're looking for it in your assessments and that you're giving them the correct rehab at the other side. Recovery is an interesting one, because what is recovery for a jockey? Recovery is, when am I back racing? That's all that they want to know, understandably, and when am I well enough to go back race riding? And for us, it's really to make sure that that jockey is safe, both for themselves, that they've recovered enough to safely ride a horse for themselves, and that if they were to get another fall, that their brain had recovered, and also for the horses and jockeys in that race. We need every jockey to be safe and fully recovered, because the risk that they pose to everybody else in the field once they line up alongside them. So recovery can be difficult and challenging. There's certainly the suggestion that the physiological dysfunction in the brain may take longer to recover than the clinical signs. So a jockey can come into you, be clinically very well, be passing all of the assessments and doing really well, but the concern is, has the brain actually fully recovered? There's also the question as what happens when we say you're medically cleared. Instantly that rider wants to be back up and the horse competing the next day. Would certainly say this introduction of what we call a buffer zone, which is a period of time where you're back riding out, riding, work and schooling before you go back racing, because coming out of the doctor's office who says you've recovered from your concussion, because we can't recommend you go back riding, you can't go back race riding until you've had a period of riding out. It's like the contact sports where they go back to contact training for a period of time before they're allowed back to compete in the match. So I think we certainly need this time, this gap that allows people to get back riding out once medically cleared before they're cleared to race ride, which is obviously the higher risk And there's no single criteria for recovery, and the authors will concede to that they can't tell you, bang, this is the one individual marker that tells us you've recovered. And as such, then they don't have what we call a minimum recommended stand down time. That's often what we get asked in terms of the rules and the policy. How long are you going to stand this jockey down for? And we can all go back to the days, I think you mentioned it already, Jerry, where a loss of consciousness immediately meant 21 days. If your loss of consciousness was more than 3 minutes, it meant 28 days. If you were just a little bit confused, it was 5 days. So the treatment and the rehabilitation and the recovery is now very much individually tailored towards each jockey. And I think that's a positive. I think for those jockeys who perhaps it might be a dubious, you're erring on the side of caution, but the next day they genuinely don't have any symptoms. They fly through the return to ride protocols. They do really well. And for those guys, we're a little bit like, well, you know what, if you genuinely didn't have a concussion or you have recovered well, it allows them to get back at 7 days. So in Ireland, we'll keep the stand down day at a minimum of 7 days, but really you have to manage the expectation. So for most jockeys who are concussed, we will say to them, you're really realistically 10 to 14 days. If you get back for 7 days, that's, you know, a huge bonus. But for the majority of them, despite what they may be arguing with you on the day that I'm fine, when you talk to them the next day and the following day and you do the assessment, they can be very clear with you, actually, you're right, it is going to take me 10 days, or after 7 days, yeah, I'm happy to sit this out another couple of days because I'm not fully back to normal yet. So it's all about how you manage those expectations. It's about how you manage those expectations. We're fortunate in Ireland that we do have an independent body who will do our final assessments, so we'll be rehabbing them along the way, doing the assessments. But when it comes to their clearance, we use a team in Santry's Sports Medicine Clinic, and they'll do this go at 6 from here on. They'll be comparing that to the office assessments that we will have done. They assess the vestibular ocular system, they do the Buffalo treadmill test, and we also have a baseline neuropsychological test, both computerised and pen and paper. It's the same in the UK. We baseline every 2 years. So we'll repeat the neuropsych tests, which will be compared to baseline. So it's, I suppose, fairly robust that we can be as clear as we can be that somebody is recovered. And we don't let them do that assessment until we're very confident that they're going to pass it. And I'll often say to them, there's no point in pushing, and we really want to get back. That I can tell you now, you're going to fail that assessment and then you're going to delay your return. So try and sit tight until we're happy that you've certainly recovered. But it is challenging. We use, the detail in this hasn't been updated, so, but I know Jerry has something similar to show you in a little while. These visual aids can be really important for a jockey to give them some structure. You've already seen some of the videos that we've used. So the visual aids and the technology available to us now makes a lot of this much easier. Remote calls, which we've become very familiar with in COVID, means you may not always geographically, someone's 2 or 3 hours from you and they're not going to get you, and they can't drive anyway because you don't want them driving concussed. You can do a certain amount of the assessments and at least be explaining and articulating what you need that person to do on an online call. But I think the most important things through the hours that I've discussed with you are, and again, this is probably for the regulators, to make sure you have healthcare professionals who are trained, you have a facility on the racetrack, you have somebody who can do the SCO at 6. That you have removal and return to play protocols that are strictly enforced, and that you're managing the expectation of the jockeys to make sure that we're giving the best care. I appreciate that's a bit of a whistle-stop tour. This is my own concussion story 12 years ago now, a very unflattering picture of me this is what I look like when I'm concussed, with that kind of bewildered look going, what's going on? And I'd say a lot of us, both in this room and online, we all have our own concussion story, because whether you're a jockey or whatever your background, concussion is common, and it is absolutely incumbent on us that we manage it correctly. So I'm going to hand you back over to Jerry.
Thanks very much. Thanks, Jennifer. I wonder if anyone counted how many members of staff it took to look after Jennifer when she had her concussion?
Very important person.
8 members of staff, so there you go. Darry, can you just give me a bit of a time check? How are we doing for time?
You have another
15 minutes, okay. We've covered all the cues, so that's fine. Okay, so I'm going to speed up a little bit here and just go through some of the next R's. Now, a lot of this, what I'm going to talk about, has been covered already by Jennifer. So looking at this is return to learn. And return to learn is part of the return triad, so return to learn, return to work, and return to sport. And of course, in professional sport, returning to work is returning to sport, so it's one in the same for the most part. So looking at return to learn is returning to learn, one might assume in racing actually is not terribly relevant, because there are very few of our participants who are actually still in full-time education. But a lot of them may be in part-time education, and you often get caught out by your senior jockey who's actually preparing for retirement and may well be actually doing some study as well. So don't always assume just because they are mature that actually they are not doing some studying. So in the consensus statement, they give us a nice definition, and the great news is for return to learn, which takes place before return to sport, actually most are back within 10 days. And the same process, this same graduated process, which is getting people going on day one, getting them engaged, getting them doing their daily work in a safe environment, applies just as much to return to learn as it does to return to sport. And in the consensus statement, and you'll see the return to sport section in a second, you will see they've done this stepwise progression. And for both return to learn and return to sport, the first half, so in this section 1 and 2, are deemed to be therapeutic. So this is your treatment section, and the second half is actually building up resilience and capacity, whether that's resilience and capacity to learn or resilience and capacity to participate in your sport. As Jennifer's mentioned, actually looking at those individuals who don't do as well, that's those with a high burden symptoms early on, and also in the learning situation, we often find those with pre-existing learning difficulties, ADHD, dyslexia, and similar conditions do struggle a bit. And interestingly, in racing, we probably have slightly more than the average number of jockeys with those conditions compared to the average population. So returning to sport, again, this is the stepwise. So where we have here, we have a 6-stage return to sport. Jennifer's touched on a lot of this already. So in this version, the first 3 stages are therapeutic, and this is where you avoid further risk. Although by stage 3, you're looking at some sport-specific work. This is a real challenge for us in racing because sport-specific work, apart from sitting on an equaliser, involves sitting on a horse. And as soon as you sit on a horse or your horse facing, even at ground level, your risk increases. And so this schedule really works well for field sports, for rugby and football, but actually for racing, I think we need to take a slightly different version. And certainly the closest we can get to sports-specific work outside of the gym would be on an equaliser. And it may well be that the sports-specific work and a preliminary clearance to sit back on a horse takes place before the end of this schedule. So in terms of where we are with our guidance at the BHA, this, and I want to just acknowledge Rosie Hyman here, who's our concussion practitioner, who's designed and just launched an education programme and some appropriate guidelines to go with it, is that actually, in contrast to the Irish scheme, where actually we're getting people back on a horse at stage 4, we've pushed it to stage 5 because of this hazard, because you cannot guarantee anything you do with a horse is safe. So for the jockeys, it's the same schedule, but actually because these jockeys are fully engaged with supervised rehab, it does happen more quickly. And we've already mentioned CSIG says each stage of 6 stages takes 24 hours minimum, so in theory you could be back at 7. Actually, if you look at the data, they may say that's possible, but the majority of people on the consensus statement actually got back at about day 18, which is ironic because when actually we looked at our data in UK racing, for jockeys getting back to competitive riding, 18 days was the average. Now, clearly, when you have an average, you have some people who are quicker and some people who are longer. So it's really quite interesting that there's this chat about 7 days, but it is pretty unusual for an individual to get back at that time. Okay, so reconsider. So this is looping back to the opening few slides ago. This is the hot topic for the lawyers and the class actions across sport. So what are the long-term sequelae of concussion or repeated concussions? And we have some challenges in this area teasing out the information because a lot of things affect brain health in later life. So smoking, blood pressure, genetics, education, entertainment. It's not just all about how many head impacts you've had, but they probably contribute in a fairly significant way. And I'm using the term here head impact, not concussion, because there is certainly a difference between what is termed a subconcussive impact, so that is a head impact without a diagnosis of concussion, and a formal diagnosis of concussion. And there's a school of thought that actually that's a combination of all these head impacts over time are the ones which contribute to long-term issues with brain health. The difficulty always is if you're trying to look at evidence, it's designing a study which actually measures the number in absolute terms of head impacts. It is very difficult, and most of the studies actually look at the duration of your professional playing career. So if you look at this, briefly, it shows that former athletes in collision sports had no increase in mental health problems, depression, suicide, hospitalisation. In amateurs, there was no increase in cognitive impairment or neurological conditions, so the dementia, neurodegenerative disorders. But in professionals, it did make a difference. So in professionals, there are a high number of deaths from neurological disease in American football. And in American football, there seems to be a dose-response relationship between the development of CTE, chronic traumatic encephalopathy, and the duration of your career. So once you start to have a longer career, presumably you have more head impacts, and therefore your risk of getting long-term brain injury is increased. But that's only on duration, not yet the number of impacts. So I've got Dara who's touching his watch here, telling me I need to crack on here. So there are issues here, and I think one thing is from a racing perspective, what do we need to do about this? We need to be aware, and I think moving forward we need to be trying to record the number of falls and the concussions in a longitudinal fashion for the individuals so that we have the data if we ever reach a point where we know that actually there is a threshold either per unit time or total number of impacts per year. Two final sections. So the retirement, what we hoped for as practitioners that CSIG were going to come up with if you've had this number of concussions, you should now retire. They didn't do that, and understandably. The thing about the retirement is there isn't a single factor, and it's one of those things, it's a discussion that takes place between the medics within the sport, sometimes outside the sport to get an independent view, between the athlete and their family. And it's influenced by what else they've got available to them. So if you're a jockey who has a plan B, who has already planned their post-professional sport career, that might just get put forward. If you don't have that plan in place, you're more likely to wish to carry on for longer because actually you have to put bread on the table, you have to pay your mortgage. So it's a very difficult but a very individual conversation which needs to take place. I'm going to skip over parasport for the moment because we are short of time. So just going to loop back to the beginning. We're talking about Zachary Lightsart. So if you remember, I asked you to remember this. So education. The graph you can see below is the outputs of the survey we did from our equestrian meeting. And just briefly, at the moment, of the respondents, 18% said that education was mandatory within their jurisdiction, but actually the other 80% wanted to introduce it. So there is definitely a desire to get education for all participants. We mustn't forget medical staff in that. Jennifer's already mentioned, we need to make sure they actually know how to use the tools available to them. What about immediate removal from the field of play? Well, on the respondents to our survey, we found that actually only 80% of events had healthcare practitioners in attendance. I don't believe that's correct because I can't imagine there would be a race meeting without at least a first aider there. Most of us have time to make the assessment, but only 2/3 actually had a suitable location to do it. So Jennifer's mentioned about a quiet area, really important. Not all fallers get assessed for concussion, but that's probably because they've got much more significant injuries. On the clearance piece, what's happening currently is the majority of respondents said there is a minimum stand-down period. The majority of respondents said that the sport internally decides about when someone should return, but only 1/3 were using an independent assessor as well. And having an independent assessor will give you resilience if you're ever challenged. We mentioned multimodal testing that's used currently in 2/3, but the aspiration is to have it across the piece. So final slide, Darry, we'd be delighted to hear. So on this, protection for all. What is our suggestion? What is our ask of the IFHA? Really falls into three areas. First, we believe there should be education for all, and that is education for all. It's not just the jockeys, it is the medical staff, it is the valets, it is the stewards, it is the staff within the yards, because we know that actually concussion evolves over time and we need everyone to be supportive in helping us with the diagnosis. We also need to make sure that racing processes support the assessment, diagnosis and rehab return. So that means we need to make sure we have time between races where you can use this gift of time, which does not exist in rugby, to actually make sure we do an assessment. We need to make sure there's adequate facilities, that's facilities for the assessment and facilities for rehabilitation. We need some protocols. We need some protocols that says this is what you should do if someone falls, and I would suggest we need some protocols to assist with decisions around retirement. There are many, many racing nations. There are many jockeys who fall. There are many jockeys who get concussed. Let's get that data together and actually make sure we have the right information to plan for the future for the protection of our sport. Now, will that protect us from the lawyers? They're probably still interested, but nonetheless, I think we can build in some resilience here. So these are, interestingly, largely what the Zachary Lights-Out law suggested in 2009. So I think it's probably time we got there, albeit we are 14 years a bit late. So thank you for your attention. These are some of the information we've put out now for our concussion education programme in the UK, which has been incredibly well supported by the Injured Jockeys Fund, who do most of our rehabilitation. Rosie Hyman, I've mentioned, our concussion practitioner, and funded through the Racing Foundation. Thank you very much. Tom.
You can have a seat.
I will. I'll have a little lie down now, actually.
Dr. Jerry Hill, Dr. Jennifer Pugh, thank you ever so much. We'll now have a Q&A session. Those of you in the audience here, or those of you at home, if you have anything to answer, anything to ask even, please do let me know, let the team know. You can submit questions online through the Zoom that you're watching this on, or just raise your hand in the audience. Just to kick things off, if I can, and feel free to, one of you answer it, both of you answer it, however you want to play it, really. Off the back of the consensus statement on concussion in sport, is there one key takeaway that you would give in terms of applying the findings to improving jockey safety? Is there one biggest area, do you think, Jennifer, first of all? Oh, yes, there's a mic. That would help, wouldn't it? Jerry, have you got yours? Behind you.
Okay, fantastic. Thank you very much.
You should be able to turn them on there if you can manage that.
It's already on, apparently.
Don't think it is. Is it? Okay, there we go. Yeah, I do, but I think I just switched that on. I'm going to claim that as a win for me. Are you on, Jennifer?
Yes, I think so.
Go for it.
You started with a really difficult question, to be honest, because someone asked us a few months ago, is the consensus statement, is it a very long document? And it's not a very long document, but as such, as Jerry said at the time, every word is very important within that document. So we could absolutely say the recognise and remove piece is the most important, that if you don't get step one, none of the rest of the steps matter. But the re-evaluation, rehab, recovery, I would find it very difficult to pinpoint that. For horse racing, though, I think, and it probably depends on where each jurisdiction is in their journey along concussion management, but if you're not doing the recognise and remove piece yet, that's your key starting point. And obviously, I think we're quite fortunate. We're probably further along that journey in Ireland, and so for us, it's now around focus on decisions around retirement, around that determining what recovery is. So I think it probably depends on where you are along your journey.
Jerry?
I think the benefit of the statement is actually gives you a roadmap, and I think you need to start that journey. And if you're working in professional or indeed amateur sport or indeed medicine anyway, you need to have a full awareness of this document and actually begin to apply it in your jurisdiction. You can't do it all straight away, but I think if you start that journey, use it as a guide, and gradually work your way through it and take out the bits that you can deliver. But some of them are low-hanging fruit. And for me, which is why I ended on this, is whilst it's perhaps not a section within the statement, it's that education piece, because we need to make sure that everyone who's working within our sport has an awareness of concussion, because the responsibility for looking after the concussed individual belongs to all of us. It is not the doctor's job alone, and it's not a question of actually passing the doctor and then carrying on with your concussion untreated.
And you touched on other sports throughout that piece there. Have you both seen a big cultural shift in societal awareness when it comes to the risk of concussions to athletes?
I think certainly, and probably for better or worse, a lot of that has been driven by the legal eagles and the lawsuits that have happened in the States. But that's not to say that that's a bad thing. It has brought this to the fore. I'm actually just reading the book at the moment, Concussed, by, I've forgotten his name now, which is terrible, the rugby journalist. You know, it's very interesting, the journey different sports have been on, and I think we're probably quite fortunate that we are certainly on the curve, if not somewhat ahead of the curve, in how we've been managing concussion in certain jurisdictions for several years. But yeah, I think it's very prevalent. The Rugby World Cup is there at the moment. If anyone follows NFL, it's constantly on people's minds. Whereas now it wouldn't have been spoken about before, other than maybe a jovial, oh, he was knocked out and he's back on the pitch again. You know, whereas now people are horrified if they see somebody who's clearly concussed being allowed back on the pitch. So the awareness has helped.
Do you think that other sports, particularly those you mentioned there, and their participants are more open to the concussion protocols than perhaps jockeys might be? And if that is the case, what are the reasons that perhaps, and we're going to be covering this with Tom Scudamore, who's in the room later on, what are the reasons that perhaps jockeys compared to other athletes might not be so open to said protocols? Jerry, first of all, if that is indeed the case.
Well, I think that if it is the case, that is a question for Tom for later. But I think what is interesting, of course, is that the concussion protocols in racing, certainly in our two jurisdictions, have been routine for a long period of time, and that's down to the work of my predecessor. So it is routine, and it's got so routine we've actually perhaps forgotten to highlight the importance of it. We are not talking about it as much as we should do, and what's happened, we've perhaps relied on the protocols to do the work for us when actually we need to spread that burden amongst the whole of the industry.
It was something that you touched upon pretty consistently there, was sort of examples of riders almost half jovially sort of suggesting, I'm fine, I can get back to riding. And I guess that's there's a balance there between you not being detrimental to their immediate careers, but earnings-wise, etc., but also looking after them in the best way possible.
I think that's right. I mean, there is athletes as a breed, jockeys specifically, are very driven. What they do is ride horses, and depending on their arrangement with their owners and trainers, of course, their income is dependent upon them riding. And whilst a lot of us have income support schemes, and certainly we have one in the UK, which does pay a significant sum if you are not able to ride, it is not the same as riding. And so there is that drive to actually get back. And the other thing is, I think it's less now, but it's still around. It is probably that I'm tougher than this, I can get on and do that. And it's really actually saying, well, actually, that is not good for your long-term health. It's not good for your performance. And what's really interesting is, if we talk to jockeys about, you know, if you go back early, to be honest, none of them are very interested in the long-term issues. What they tend to be concerned about is, if you get back on that horse, you're going to ride poorly and people will judge you, and that will affect your next ride. That seems to have more resonance with a jockey than actually saying, well, you might get dementia a bit earlier than you were planning to get it anyway. So that's really important. That's performance, because they are athletes. That's what they do. They do their sport.
Did you have anything you wanted to add, Jennifer?
Just that there's always a constant line that you're walking, in that balance between allowing somebody back from injury, whatever that injury may be. But you might be able to shave a couple of weeks off a collarbone or a wrist fracture. You're not going to shave time off a head injury, because it is too important. The risk of them not being fully recovered and being back is much greater than if you fall on a collarbone that hasn't fully healed yet. So it's really it's a non-negotiable, really, in terms of the concussion recovery.
Just something that occurred to me while you've both been speaking there, and perhaps this will be useful for people watching at home and in the room, who are looking to fulfil the roles in their jurisdictions that you do currently. Should you exist as a jockey's friend?
there's a balance there as well, isn't there? It's about communications. My boss is in the room, so I have to be careful here because I work for the regulator in the medical sector, and the medical department falls under the regulator. But then I'm also a medical practitioner and a doctor, and I would generally be of the mindset that once we're not breaking any rules, I am absolutely your advocate because you know, I'm a doctor first, and you know, my employer comes second. But it is a fine balance, and you have to stay within the rules, and you have to make your jockeys stay within the rules because it's for their own health, safety and welfare. That's why we're here. So,
And I would agree with that. I mean, we are doctors and we are patients' advocates, but sometimes being a patient's advocate doesn't mean doing what they want you to do. And certainly way back in medical school about 100 years ago, we had sessions on patients as friends and friends as patients, because it can change the dynamic. And certainly if you're in a regulatory situation, then actually you do need a degree of arm's length. That doesn't stop you being friendly, but actually being friends sometimes does muddy the waters.
One final point, excuse me for reading here, just to get the wording right. With racing being ever more global, are jockeys starting to expect certain levels of consistency in concussion management, no matter which jurisdiction they're riding in, Jennifer?
I think that's fair. Yeah, we do see a lot of movement of jockeys between different jurisdictions now and in different seasons. So I absolutely, and it wouldn't be uncommon for a jockey who's riding abroad to call me to say, look, I've had this problem or that problem, and I'm just not sure what the protocols are here. And I think that's probably one of the main benefits of our association with the IFHA and having this conference up and running, is to try to get some harmonisation between jurisdictions, that we have at least that hate to use the word a minimum standard, but at least we have a standard that we're all working towards.
Jerry?
Yeah, I would absolutely concur with that. And one of the great pleasures of working with Jennifer is the fact that her protocols and the protocols in the UK are practically identical. So we know that a lot of jockeys who move between the two jurisdictions will get the same level of care, which is great. And certainly that will be nice to see that more widely spread.
Anything from the room that anyone wanted to ask Jennifer or Jerry?
I'm Dr. Chu from the Chief Medical Officer from Hong Kong. And first of all, thank you very much, Jerry and Jennifer, for your inspiring talk on concussion. And I have a question for both of you. Are you currently adopting the SCAT 6 protocol in your jurisdiction? And also, do you think it needs more validation before we adopt this SCAT 6? Thank you very much.
It's a great question, because we know SCAT 6 does need some more evidence behind it, but indeed so did SCAT 5 when it came out. So I think actually the bigger barrier is actually getting it disseminated and making sure that medical staff are trained to use it. It's all very well actually recording the information, but it's knowing what that information means and what do you do with it subsequently. So for the present, we're running with SCAT 5 until such time as the cohort of medics, and we have probably 250 doctors across the racetracks in the UK, until they are appropriately trained. But it is highly likely we will move to SCAT 6. We are almost certainly going to be taking out certain elements of it. So dual task, for instance, is going to be introduced fairly soon, because that is something which is relatively simple.
I'd answer that pretty much the same way. The SCAT 5 is still what's happening on the ground. I personally am using the SCOAT 6 in the office assessment, really, to try and become familiar with it and to get, not practices, I'm not practicing on our patients, but to become familiar with it and to, so I don't have any issue with using that in terms of my clinical assessment at the moment, albeit we are waiting the further validation of the tests.
Anything else from the room? No? Lovely. I think that's about us. Excellent. So we will now have a half an hour break, coffee break, whatever you want to call it. We will return local time at 11:15 for the next section, which will centre around spinal injuries. We're bang on time. There'll be lots of outsiders potentially landed this weekend, but none bigger than us sticking to time currently, so that's a miracle. First of all, just one more round of applause, if you will, for Dr. Jennifer Pugh and Dr. Jerry Hill. Thanks ever so much.